This session is called Where Are They Now? It'll be facilitated by Dr. Sarah Dalton. She's the clinical lead at the Agency for Clinical Innovation. She's a paediatric emergency physician at the Children's Hospital at Westmead and president of the Paediatric and Child Health Division of the Royal Australasian College of Physicians. She's committed to improving the quality of healthcare through working with clinicians who understand how healthcare is delivered and recognise the opportunity for change. So this is what it's about. How have local initiatives developed, matured and spread across the New South Wales health system? Sarah's going to look at a selection of previous award-winning initiatives to see what they're doing now and what lessons have been learned. So initiatives such as these are showcased on the Innovation Exchange, which is a platform that promotes innovation and improvements to health services and recognises the commitment and expertise of staff working in the New South Wales health system. Let's hear all about it, please. Welcome, Sarah.
Thank you, James. Good afternoon. My name's Sarah. I'm a paediatric emergency doctor and I love going to work every day. I love going to the hospital, working into the emergency department and knowing that for the next few hours I'll be looking after children and their families and helping to make them better. I really do. And I suspect that if you work in healthcare, you do too. Healthcare is full of people who really care about people and dedicate their entire careers to improving the lives of others. But if you're like me, you probably also sometimes go to work and think, oh man, we could do that better. Sometimes it's the big things and sometimes it's the little things. Like, why don't we have enough Wiggles CDs in our treatment room? Or how can we actually really connect with the GPs who refer patients to our service? The question is, how many of you have actually taken one of these problems and tried to make it better? My guess is that you all have, one way or another. And my guess is that anyone who has tried to implement change will know just how hard that can be. So today, we're going to hear 3 stories of teams who worked to make a difference. Stories of clinicians and of health services who saw a problem and fixed a problem. And they did such a good job that their work has been recognised not only in their local areas, but with New South Wales Health Awards, which would have been presented in forums just like today many years ago. I think it's always so fantastic to see the incredible work and the stunning results that are showcased at places like this. But have you ever stopped to think, where are they now? Early on in my career learning about healthcare improvement, I remember being warned about the have a cake moment. The moment when the project's finished, the data's in, and everybody's just so happy because things got better. And everyone claps, and you have a cake, and then what happens? It strikes me that there's some danger of the New South Wales Health Awards potentially being a have a cake moment for some of you. There's smiles and celebrations, congratulations all round, and then what? Where do these projects go when the Twitter feed has gone cold? Today, we are going to find out. Every project has to start somewhere. Every project begins with an idea, a challenge, or frankly, a group of people sitting around saying, there's got to be a better way. And little ideas turn into big ideas, and from little things, big things grow. The first project we're going to hear about today is about partnerships. A story about what can happen when a clinician really cares about making things better and pulls together a great team who work with them to fix a problem that had been bugging her every day.
I remember early on, I was constantly being called about the same problems. I was the troubleshooter. So if things went wrong, I got the call. But after a while, I thought, this can't be right. Patients are being harmed and our infection rate seems way too high. There had to be a better way. So after looking at the literature, I saw that this was a common problem everywhere, and I realised we had to do something to improve our care.
A common problem everywhere. So this could be a problem at your place. In fact, when we start looking at things that bother us, we often find that we're not alone. That's why collaboration is key. And collaborate, she did. This clever clinician got together with her local nursing and midwifery research unit and ultimately built a team that reduced unnecessary procedures by 50% and led a reduction in infection rates from 1 in 10 to 1 in 100. In fact, the project that they were working on was so compelling that a NUM who was working on one of the wards at the time said, once we saw what they were doing and that there was a better way, it was a no-brainer. We just embraced it. This NUM actually went on to become one of the strongest supporters of this project, and the team have identified her, in fact, as one of the secrets to their success. And they had significant success. The project went on to win a local health award and shortly afterwards a New South Wales Health Award. Talk about have a cake moment. But just when things were going so well and the team felt unstoppable, suddenly things didn't go to plan. Their heart had been set on a local innovation scholarship, which would enable them to further roll out the work they'd been doing. They didn't get it. It felt like a backward step. But they knew their intervention worked and they didn't stop trying. In the words of the team, they got knocked down, but they got up again. And in fact, they went on to be awarded a prestigious translational research grant funded by the Office of Health and Medical Research. So I think it's time that we unveil this project and we hear from the talented clinicians who started the project so many years ago. I'd like to invite Wendy Watts and Michelle Giles to the stage.
Hello, go ahead.
Thank you. We are the No Cordy Project, and our project has contributed to a standardised approach to the urinary catheter management for inpatients across New South Wales. So this is where we are now. After winning the New South Wales Health Award in 2015, we went on later that year to win the Australian Council for Healthcare Standards Award for Clinical Excellence. We've also had our work published in a national peer-reviewed journal, and we've worked with HETI to develop online modules to prevent catheter-associated urinary tract infections, or CAUTI. Our work and our partnerships with others provided the catalyst for the Clinical Excellence Commission program that has been rolled out throughout New South Wales.
Thank you so much. It's wonderful to hear about your project. I'd just like to go on and ask you, what do you think have been some of the secrets to your success?
Broadly, I think there's probably been two key elements that have contributed to our success, and they're collaboration and robust evaluation. I think, firstly, surround yourself with the right people and collaborate with those who can help and support you and those that have influence over others to effect practice change, and also win them over with the data. Have a thorough evaluation to convince the clinicians that your project can make a difference to what they're doing and their practice, and use that evidence to develop partnerships and collaborations and bring people together to do things bigger and better.
Thank you so much. Thank you, Wendy and Michelle.
Thank you.
Thank you. Our next story is about a project that's been many years in the making. This story began with the planting of many little seeds. Many clinicians who noticed a problem over years and years and one clinician in particular who made it her mission to gather those seeds and turn them into something bigger. This story is about persistence and never, ever giving up. At the beginning of this story, the problem was that everybody knew there was a problem, but nobody did anything about it. As the saying goes, everybody thought anybody could do it, but nobody realised that everybody wouldn't do it. So it ended up that everybody blamed somebody when nobody did what anybody could have. Truly, that was a real problem for this project. Let's hear from one of the team members now.
So whether we're physicians or surgeons or nurses or allied health working in primary or secondary care situations, the evidence tells us none of us take responsibility.
The evidence tells us that none of us takes responsibility. But as we know, someone eventually did. When I talked to her earlier this week, the clinician who ended up joining the dots and pulling everyone together to make a difference talked about the importance of their light bulb moment. It was the moment when, for the first time, they were able to use data to show that their problem was real, that their problem was significant, and that their problem was one where something had to be done. The team were able to demonstrate that over a third of the patients who presented to their service with a particular clinical issue would re-present with the same problem time and time again. Clinicians had noticed the representations, but nobody had really stopped to think very much about it. So, by showing the extent of the problem, the clinical leader who decided to address this was able to unite what had become a fairly disparate group of clinicians. The project started to take form, but it didn't happen quickly. That light bulb moment was almost 10 years ago. And ever since then, the team has worked tirelessly, going from strength to strength, patiently nurturing all the little seeds until they came to fruition. Over time, the best thing about this project has been how much it has improved things for our patients. As you can see, here are some words from one of those patients. Patients and clinicians working together is a really key component to this project. Much of the work has been driven by one of our ACI networks, and in the words of our key clinician, I never thought a network could achieve so much. Please join me in inviting Professor Lynn March to join us on the stage.
Thank you, Sarah. We are the Osteoporosis Refracture Prevention Project, or the ORP, and we've made a difference to people in New South Wales by improving care for osteoporosis and falls risk for our residents. And how did we get to where we are now? I mean, the journey started for me back in the last century, in the mid to late 1990s, and I was doing a hip fracture project. In fact, one of the original health outcomes projects, and George Rubin, who led that, I think is in the audience. And we started noticing that many of the people with hip fractures had actually been in the hospital system with another fracture before. They'd actually told us they were coming. And then the evidence started evolving that if you've had one fracture, you're more than twice as likely to have another fracture. And then at the same time, evidence evolving that there was cost-effective medication and interventions that you could halve that risk. And then plenty of audits showing locally, nationally, internationally, that we weren't doing anything about it. We knew about it, but we weren't doing anything about it. The system was actually letting these patients down. So slowly, clinicians, very dedicated clinicians who cared about trying to make a difference, started doing things in their own local hospitals, winning their own local awards, and then gathering data. So the light bulb moment, Raj Verma, who was then with New South Wales Health, analysed the New South Wales Health data and said, wow, you actually have a burning platform, he called it. I still remember that. And yeah, it was 10 years ago. But then we started the ACI Musculoskeletal Network, and clinicians had a more coordinated approach. We were sharing our stories, we were sharing our data, and they've gone on to win amazing New South Wales Health Awards, Royal Prince Alfred Hospital, Concord Hospital, and the wonderful people from John Hunter and Newcastle who have been there right from the beginning through our journey, including Michelle, actually, on the very, very early project. So it went on to sort of really make a difference. We were evaluating, we had data, and we've gone on to publish international papers together, to present at international workshops, to be kind of the advocacy platform, meeting health ministers locally, and also now informing WHO policy for healthy ageing and the healthy ageing decade to come. Now, and probably the ultimate is we're now one of the key initiatives in the Leading Better Value Care program, and Robin Spearin, the amazing network manager, and I are still pinching ourselves. Thank you.
Thank you, Lynn. And thank you for your persistence over so long. Given that you've done this for so long, what advice would you like to share with people who might be a little bit earlier in their journey?
I totally echo what Michelle said in terms of collaborating and having data, just gathering that information and being ready. But there's many stories over all that journey, but I guess the three things that stand out for me are the 3 Ps. The people, the passion, and persistence. And I did not do this on my own. I could not have done it without surrounding myself with passionate people who cared about making a difference and worked together. And really just sort of never giving up. That you don't expect, I guess, to get from your vision to your final goal in a direct line. We really followed a very higgledy-piggledy pathway. I could never have predicted or planned how we might get there. So you just had to be prepared and flexible and seize any opportunity, even rename yourself along the way because it resonated with particular people who happened to be listening. So I guess, the key thing is just never, ever give up.
Thank you so much, Lynn. Our final story this afternoon is about what happens when very special clinicians work with our most special people, our patients. This story had its beginning when a health service underwent an external review of its performance. Sometimes these reviews show up issues that nobody knew about. But in this case, one of the issues identified was very dear to the hearts of the people who worked in the service at the time. A small number of high needs patients were representing very frequently, and nothing seemed to help them. One of the clinicians working in the service at the time was so concerned about this, he realised that somebody needed to do something about it. And he realised that somebody was him. The main problem was that the service wasn't really configured to help the people who were calling so regularly. And the clinicians were frustrated because they felt there was nothing they can do. You can see a quote from one of the clinicians here. So instead of shrugging and saying, that's just the way things go around here, the clinician at the heart of this story decided to make a change. He started by finding out just how bad the problem was. And as it turned out, the numbers really supported the fact that there was a problem. In this acute care service, there were almost 1,000 patients who accessed care on a monthly basis every month for a whole year with very limited therapeutic benefit. It's about 30 times every day across New South Wales. No wonder the clinicians were so frustrated. So what did they do? Well, through the commitment and leadership of this clinician, the health service designed an innovative model which prospectively identified high needs users and offered extra support so they didn't have to wait until that crisis point to make the call. But, as always, things didn't quite go to plan. Like is true of so many projects, the team thought they'd nailed the solution, but then they discovered others in the organisation didn't quite agree with them. It's a great pleasure for me to invite Kevin McLaughlin to the stage to tell us more about this challenge.
Yeah, well, we thought off to a fine start, and we'd got our data, with good data together, and we had identified our cohort of patients that we were actually going to focus on, and developed a model of care that we was based on the evidence available. And we started to promote that throughout the organisation, looking for the support that we felt was just automatically going to come our way. But some people did raise some questions and some concerns about the direction we were heading in, because this was a major departure from the core business of what our service was set up to do, and that perhaps these resources would be better employed elsewhere.
Thanks, Kevin. So you were thinking outside the box, but it wasn't always smooth sailing. Can you tell me how you got over that particular challenge?
Well, we were still convinced that it was a good idea. And we went back to our data and we pulled the model of care a bit tighter together, and we did a trial of the intervention and rigorously evaluated that and got some good solid data together, and then presented that data throughout the organisation. And that was quite convincing. It convinced a lot of the people, but perhaps one of the important things was it convinced our acting chief executive at the time, and he put his support behind the project, and once we had his level of support, it was much easier for us to move forward and to start implementing it across the state.
Thank you, Kevin. Please stay with me on the stage for a moment. So, as they say, everyone lived happily ever after, and the project also went on to win a New South Wales Health Award in 2013. I'd really like to invite another member of the project project team to the stage now, and that'd be inviting Paul Wilden to join us on stage. Hi.
Thank you. So yeah, we're the New South Wales Ambulance Frequent User Management Programme. We work to provide an integrated case management service to frequent users of ambulance across the state. So after we won the award in 2013, we were able to implement our model across New South Wales Ambulance. What we found is really by understanding the needs of our frequent users, being able to engage with them, find out what the drivers of their ambulance use are, do some individual work with them, and also link them with more appropriate services to avoid them reaching that point of crisis which previously led to an ambulance use. Through that, we found that we've also enhanced the quality of life for a number of our patients. We've also seen benefits from, in terms of ambulance use. We've avoided ambulance use on over 5,000 occasions for this patient group since up to the end of the financial year 2017. We've also seen a corresponding reduction in transports to ED of this patient group, and a significant cost benefit to both ambulance and ED. Sorry, it's one of me patients. But the best thing is that the patients are happy.
That's so great. They're obviously happy enough to keep calling you. Can you tell us a little bit more about the patients and how they feel about this?
Can I just give you an example of one patient who's, is a very high user of ambulance? It's a lady called Faye, and we worked with her for an 18-month period. Now, prior to enrolling on the programme, this person had used ambulance on 310 occasions in the previous 2 years. When we got some longitudinal data, she'd actually used ambulance over 1,000 times in the previous 10 years and presented to an emergency department on over 390 occasions. So Faye had been disengaged from services. She disengaged herself from services, really. She was socially isolated, really neglecting her physical health and her self-care, had some significant issues with alcohol use and an untreated anxiety disorder. So through our programme, we really engaged with Faye and worked with her intensively over an 18-month period. Worked in areas around distress tolerance, providing psychoeducation, looking at behaviour activation programme for her, and increasing social activities. The programme is really beneficial for Faye and other people in her situation. In the past 3 years, Faye's used ambulance on only one occasion. So this is also, her general health has physically improved, and so has her social function and mental well-being. I think we might be able to hear from Faye at this point.
Let's hear from Faye now.
I had no interest in anything at all. All I basically did was slept, drink, watch TV. I didn't care about how I looked, presented myself, personal hygiene, self-care, around the home, just like I previously mentioned. No interest in anything at all. I was still stressed, depressed, suffering from anxiety. With the assistance of the program, if I get in these circumstances and that, I've got somebody I can call for assistance.
So how many times have you used an ambulance in the last 2 years, Faye?
In the last 2 years, I have not called for an ambulance once.
I think you should get a round of applause for that.
Thank you.
Thank you so much, Paul, and also Kevin. It's such an impressive program. Can you maybe share a little bit about what you think has contributed to your success?
Oh, look, we're really delighted with the outcome and being able to assist people like Faye. Pleased to have offered interventions to over 100 people who've been on the programme. There are many others, unfortunately, we're not able to offer intervention to at this stage, and we wish we could do more. You know, I think the secret to our success has really been engaging with patients and listening to their stories and not making assumptions really about them.
Thank you very much. Please thank the wonderful team.
Thank you.
So as you can see, a mix of passionate people, big ideas, and a willingness to never give up are the essential ingredients to making change and making change stick. We've heard about the trials and tribulations that have befallen each of the projects along the way, and we've also been inspired by the persistence and ingenuity of the clinicians who've led them. People don't always buy into your project. You can't always be a prophet in your own land, and goodness knows funding is always hard to find. But the nature of any project is 2 steps forward and 1 step back. And all these projects have just kept moving forward, making care better and safer for patients in New South Wales, 1 step at a time. I imagine many of you will recognise these stories. They may, in many ways, mirror your own stories. So what's the moral to all this? What do I want to leave you with? To quote Margaret Mead, an American anthropologist from the 1960s, "Never doubt that a small number of thoughtful, committed citizens can change the world. Indeed, that's the only thing that ever has. From little things, big things grow." The end.